Hi everybody, here we go again. We are about ready to tackle some more anti-infectives. Last week we covered your basic antibacterials, and so now we're going to tackle everything else but the kitchen sink. So here we go. We're going to go from chapter 40 to 43. I'd like to start on chapter 41, which is the anti-tuberculosis drugs. So hopefully you've covered some of the tuberculosis in your adult health or professional practice class, but TB is one of the most major world health problems, and it kind of saw a decline in the United States, and then in 1985 we had HIV come out, and we found people that were a higher population of people that were immunocompromised, and so then they were perfect hosts to take on more tuberculosis. So our numbers have been rising, and then we've got this incredible immigrant population that's moving in from all lands, and that's also impacting it. So those are who are at the greatest risk, are the immunocompromised and people that are coming from areas that have a high rate of it, and then they come to the United States and they live in a very densely populated area. We might find 8 family members in a small home or an apartment, and there's several apartments or several houses in the community that all have a high population. So the disease spreads very, very easily. So do you remember some of the signs and symptoms that people get with tuberculosis? I think one of the big ones is night sweats, fevers, coughing up blood, and I've got a great story to tell you, but I'm going to hold on for a little while. Another thing might be weight loss, and you guys probably remember we all have to get our PPD tests, right? And what that does is it injects a little purified sort of tuberculosis into us, and if we've had exposure to tuberculosis before, been infected before, it just reacts to it. Your body sends off antibodies there and has a reaction. So if somebody comes in with a positive PPD or Mantoux test, the next step then is to go to a chest x-ray, and there they'll look for granulomas, they call it, so kind of like little tuberculosis pockets in their lungs. And if they don't see anything, then they'll say, you know, you've been exposed to it, but we don't think you have any active disease. If they find something interesting on the chest x-ray, then they'll ask them to give a sputum culture, and they'll check that for active TB. Let's see. One of my favorite museums is the Hunterian Museum in London, and the reason I like it is because this doctor just loved to discover all sorts of things about the body. So he actually had some body snatchers that would bring specimens to him, and he would dissect. That's what he did, dissect, dissect, dissect. And lucky for us, he took what he found and put it in little glass jars, and they've actually kept for over 250 years, I think, in London. So I can actually walk in that museum and go, aha, look at that. That is tuberculosis of the brain. That is tuberculosis that is affected and eaten away at the bone. You know, nowadays we just don't see it because there aren't any body snatchers, and people don't keep things in glass jars, body parts in glass jars, unless you're from Wisconsin and your name is Dahmer. But anyway, it is just a great way to see how the tuberculosis can spread and the damage it can be done. So it's not just in your lungs. And I think this diagram gives a great example of all the places that tuberculosis really can affect. So when somebody sneezes, it's not just a little, here's a couple germs, but this picture, look at it, it goes everywhere, right? So droplets go everywhere, and these droplets land on anything in its path. My computer, my desk, my books, my marker, my can of soda, everything would get covered in this. So it's very important that when we have patients with TB, that when they come into the hospital, they go on special isolation. It's not just droplet isolation, but it's usually a reverse airflow isolation, and the staff has to wear those, I call them Ghostbuster costumes, or at Gunderson they call them PAPR, special hooded masks with actual tubing that goes and does kind of a airflow exchange in there, because we don't want to get it and then take it on to some of our other patients. So until they're deemed inactive with tuberculosis, that's kind of the procedure they go through in the hospital. So a long time ago, they used to think, tuberculosis, I know, a nice vacation in someplace lovely and warm with lots of fresh air will take care of it. Yeah, we soon realized it's not that easily treated, and all of these huge, glorious, beautiful sanatoriums that they had for TB kind of fell into disarray. And if you ever watch America's Most Haunted, I swear every show includes a gorgeous building that used to be a TB sanatorium. So now we don't send people to exotic locations for their TB, but we medicate them. We try and get rid of the infection. And the process is usually a two-phase process, and the first part will be a 2-month treatment, and it'll include 3 to 4 drugs, and then phase 2 they might take them down to 2 drugs. So can you imagine having to take 3 or 4 medications? And some of these medications are several times a day. So not going to surprise you that these don't get tolerated too well. A, there's the fact that you have to remember to take all of these medications. B, super expensive, and oh my, if you only knew about some of the side effects that happened with these. One that we see quite frequently is INH, isonazide, or sonazid, I think it's pronounced, but really I've only ever heard it pronounced as INH. So that's one of the main drugs that we use for TB. So some of the other first-line drugs are listed here. Rifampin, that's kind of a funky one because that will turn your urine orange. Have you ever heard of the term synergy? So drug A has this effect. Drug B has this effect. So together they would have, you would think maybe this effect when you add them together. But on their own it's this much and this much, but together they actually have tons and tons of effect. So synergy is when you use 2 medications together and they actually potentiate each other and you get an even bigger impact with your treatment. And I think of this like a narcotic and an antiemetic. Narcotic will take care of the pain and antiemetic will take care of the nausea, but you put them together and it potentiates the effect of the narcotic too. So there are some medications when you put them together they become stronger, and I think that's the case with some of these medications. Rifampin, we use that with other medications such as gentamicin or antibacterials to treat some severe infections such as endocarditis. So here's a situation where the patient will be on a couple of these medications. So there's first-line drugs and there's second-line drugs. And in this one, the second-line drugs, they just don't have the wow. They're just not as effective and they're more toxic. So they try to use the first-line drugs right away, and hopefully they don't have to go to the other drugs. So INH, one of the side effects that I swear almost everybody gets when they take it is neuropathies. Their fingers and their toes just becomes pins and needles, and it usually happens within a few days of starting the medication. So something that we can encourage our patients to do is to take vitamin B6 with the medication, and that will help prevent it. So INH, with administration of it, it's usually given without food to help with better absorption. If you start taking it with food, the medication's not going to be absorbed as well. They're not going to get as much medication as they need. resistances can further develop, and treatment's going to be a failure. So it's something very important to teach your patients. Okay, so we have a patient who's developed active TB and was started on INH and rifampin, as well as probably a third or fourth drug. So which should the nurse include in teaching the client about taking this drug? What are we going to tell them? Are you thinking about it? Yep, actually all of these except for E. So INH should be taken without food. They should have eye exams because these medications can affect their vision. It is crucial that they follow the medications and the regime that is set up for them. And then reporting that numbness and tingling, because we can help prevent that with vitamin B6. But the client's body fluids will not turn green unless they're part Martian. You're actually going to see them turn more of, well, not them, but the stuff that comes out of them, more of an orange color. I remember walking into a patient's room and looking down at his Foley urine collection bag and going, oh my gosh, what is going on? And the nurse looks at me and goes, it's okay, he's on rifampin. Now that's a good nurse to remember that. So now we have antifungals, and I think it's kind of funny because it's actually anti-fun gals. So these are what I imagine a dust bunny to look like. They're kind of furry and fungal, mold, yeast fall in this category, and there's really two sort of infections with fungus. One would be surface, so on the skin, and sometimes you can see that as kind of a rash, and it usually has a ring around it. And all you need to do is take some topical antifungals and put it on there a couple times a day, and it's usually okay. Systemic infections is when it gets scary, because there is no way, shape, or form that yeast and mold, fungus, that sort of stuff belongs inside our body. So when I have a patient that has a positive culture come back for fungus, I go, uh-oh, we have bigger problems here. So some of the antifungals that we use, another one that you'll see, and you'll see this commonly, is thrush with patients. In the mouth, they usually have white spots. Sometimes they're red spots, but usually white kind of patches in their mouth. So different kind of categories for these drugs, but I kind of put them in yellow, the ones that you're going to see most often. Just looking at the list, meconazole is a cream vaginal suppository for yeast infections, which you can buy over the counter. Fluconazole is a tablet, and same thing, it can be used for vaginal infections, vaginal yeast infections, and sometimes other infections. And then nystatin is what you use for the thrush. And then amphotericin B and caspofungin are two IV medications that we give patients. And I haven't seen much use of the other two that are in white. So we'll kind of talk about these a little bit here. So contraindications to antifungals is, first of all, if they have an allergy, shouldn't be getting it. If they have liver failure, these medications tend to cause liver enzymes to bump up and can further, I guess you could think of it as cripple the liver, or they can put somebody into renal failure. So if they have liver or renal failure, we do not use them, or we really decrease the dose to the minimal needed effect. So now that you know these are reasons not to use it, what do you think the adverse effects are for the drug? Exactly, liver failure and kidney failure. So it's very important that we use pre-medications with the IVs infusions. And some of these pre-medications could be Tylenol, sometimes Pepsid, like a histamine blocker, so that they don't have an allergic response to it. As steroids I've even seen used, and infusing them over 2 hours, but more like 6 hours, because you're giving it to the patient a little bit slower, so hopefully they're not having a big reaction to it. So, fluconazole. I love this picture. Diarrhea. And the reason it's there is because that's one of the side effects of diflucan. So the recommendation is to have the patient take it with food to decrease the GI effects. So what they usually do is give them a 400 milligram dose, so it's a higher dose, and then they usually drop it to 200 milligrams once a day for the total course of 7 days or 14 days, whatever the decision is made based on the cultures. So there is a situation where if a patient has a yeast infection, they may give them just 400 milligrams, one dose, and be done with it. That is very effectual. So that's what you need to know. Oh, the half-life of it is 20 to 50 hours. That's why you give them the big dose and then drop the dose, because it's in them for a long time. So if a side effect is diarrhea, then of course they're going to get stomach cramps too. So I encourage patients to eat yogurt, kind of try to restore your normal flora in your gut. And then just know it's a short-term course usually. So when teaching a client who's taking diflucan, what is the priority for the nurse? What are you going to teach them? They're not going to get neuropathies, so you don't have to worry about the vitamin B6. And we just talked about the fact that they should take it with food to diminish their GI side effects, so B isn't right. D, they don't develop gum hyperplasia, so that's not right. So it's actually C. Now these oral sulfonylureas, I'm not sure if you've talked about them yet, but they are anti-diabetic agents. So to know that if they're taking oral agents for their diabetes, they have a higher risk of dropping blood glucoses when they're on this medication. Okay, so here we go. Actually, is that not the coolest picture there? I think it looks like some funky hairdo on a doll, and you know, we might see it marketed for Christmas time. But this is a fungal spore, and here is amphotericin and caspofungin, which are the two IV medications that are antifungals that you'll see. And we just talked about how if you slow down the infusion, they seem to have a lower rate of reactions to the medication. Another trick is to hydrate them. So, oh, you guys, I'm going to go. Sorry about that. It's after 10 o'clock, so it must be past my bedtime. And to give them fluid beforehand and make sure their creatinine is more in a normal state. Sometimes we give them fluid afterwards as well. So nursing interventions with the AmphoB. It says here monitor vital signs every 30 minutes, but I think the recommendation is when you start an infusion of amphotericin B, that you stay with the patient. You give them their pre-medications, stay with them for at least the first 15 minutes, just to make sure they're going to do okay with the infusion. You know what? Most people do, but you want to be there in case they don't. So, let's see, I think we've talked about all this. Monitoring the urine output is essential because if they're going to go into renal failure with this medication, you want to know about it, right? Checking daily weights. If they weighed 100 kilograms yesterday, you've given them the amphotericin B, and now tomorrow they're 104 kilograms. Something tells me that they're retaining fluid, that their kidneys are not working the way they should be. So we're also going to check electrolytes like his patient's creatinine, BUN, liver function tests, and make sure they're within a normal. Okay, so here's a question for you. What are you going to do if you're in there with the amphotericin B, la-di-da-di-da, and all of a sudden the patient starts to shake and shiver and develops a fever? Do you step out of the room and go get help? What do you do? Probably the quickest thing to do is turn that medication off and call for help from in the room. Check your vital signs so you know what you're dealing with. Is this patient deteriorating quickly, or are things okay? You might just need a little extra help in there. So nystatin, we talked about that. This is for patients who have thrush in their mouth. It's Oral nystatin can also be a powder. Think about your patients who have very large breasts and they tend to get yeast infections underneath their breasts, and groins where there's that redness. Sometimes it's a rash, sometimes it's just kind of a raw redness. So there's nystatin cream, there's nystatin powder. It seems like people seem to like the powder better because it's dry. You're not adding more moisture to those areas that are already warm and dark and wet. So if we're doing oral nystatin, two completely different medications, right? Topical comes from a tube, oral comes from a bottle. Liquid, it's yellow, and it's probably, if you think of those Smarties, it's like liquid Smarties. It's that sweet. So most patients don't really appreciate it. And they take it after meals because you don't want them to eat and take all the medicine off. So after their meal, they usually chug back a couple milliliters and swish it in their mouth, swish, 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 swish all over so it hits everywhere. And then I usually have them swallow, because if they have it in their mouth, chances are they've got it in the back of their oropharynx and possibly down their throat. So if we had them spit it out, then none of this gets any treatment. So I usually do a swish and swallow. And if their throat is particularly affected, they have a sore throat associated with the thrush, they can gargle it as well to make sure it gets really good coverage back there. Okay, somehow this slide got switched around, and let's talk about how amphotericin causes renal failure. Oh, we could talk about it for hours and days. There's a whole lot of ways of doing it. Here's what happens. That's all you need to know. And for those of you who like really random trivia, it's there for you. So then we'll talk about flagell. And it's also something that can kind of cause some crazy urine like the rifampin. But this time it causes more of a dark red-brown color. And it gives people a weird taste in their mouth, kind of a metallic, bitter taste. And oh dear, please tell your patients to never drink alcohol while on flagell, because it can give them this crazy dulciferum reaction, which causes facial flushing, sweating, headaches, slurred their speech. They feel like dog poo, and they probably look like it too. This is a medication that people take when they're trying to stop drinking, and then when they take alcohol with it, it causes this icky reaction. So yeah, flagell and alcohol are not friends. So then we're going to go talk about a little bit about antivirals. So we think that, you know, you get a virus and you just got to deal with it, right? So now what if you were a cancer patient getting chemotherapy, or had HIV bordering on AIDS with really low TMB cell counts? So your body just can't mount a response to the flu. So a healthy person thinks, oh, poor me, but then you're an immunocompromised patient, you can become so ill. So we actually do use antivirals with the immunocompromised patient if it's within the first 48 hours. That's when we use the Tamiflu. Otherwise, it's kind of like they just have to get through it. So you probably won't see this very often. Amantadine, rimantadine are two others that we see. Not much else to say on that. It's usually dosed once a day. So then there's acyclovir, and notice the capital VIR, virus, vir, love that it's that simple for you. So it's used to treat herpes simplex, herpes zoster, which is shingles, varicella, chickenpox, and CMV, cytomegalovirus. So I don't know, you guys probably haven't seen many people with chickenpox, but it develops a little red rash, and then it kind of looks like a blister on it with fluid inside of it, so they call it a vesicle, and it's contagious. So we try to treat people that have any of these, and we use an antiviral. Shingles, which is the herpes zoster is real interesting because it's usually on one dermatome, and you'll learn, if you haven't, about dermatomes on your body. So it's like one area where a nerve runs, and it's just one side. So develop this weird rash, but just on this side or just right here. I can see it follow people's eyes, and it's pretty funky looking, but you'll know it when you see it. So this is what we use, acyclovir. Probably the most interesting piece of that is that it can cause blood dyscrasias, such as low platelet cell, which is the last thing you need when you've already got a viral infection going on. Some people say they get a headache with it. But this is one of the drugs, the antivirals, that do cause that gingival hyperplasia. So they start to notice gum swelling. So it's very important with these patients that you teach them to use good oral hygiene, to rinse with some sort of mouthwash to help get rid of the bacteria. So interestingly, we usually use tablets for these patients, or capsules, pills. But sometimes you'll have patients that are really quite ill and they need to be given IV. I had a patient who had CMV in her GI system, so there was no way that a tablet was going to be appropriately metabolized, absorbed, and excreted. So we ended up giving her IV acyclovir. And it's a medication that we don't push. We usually give it over 60 minutes. We monitor all of their labs because it can also impact the renal function. It's important to keep track of their urine output as well. You know, I'm just to a point that if a patient is in the hospital, we need to keep track of their urine output because it gives us a great idea and an eye into how well their body is functioning and how well their kidneys are working, how well their heart is working to deliver blood flow to the kidneys. Just check urine output. Can't go wrong. Assess for superinfections. So treating them, they may have something else pop up that's from the normal flora too. And we usually say, take lots of fluids with these antivirals. Now, if they end up having herpes, genital herpes, then it's important to make sure they either abstain from sex or use condoms until they're done with their course of therapy. Malaria. It's kind of a scary drug, and we're so fortunate not to have to worry about it much here in the United States. It's a protozoan disease, and the tricky piece with that is you can get bit by a mosquito and have no side effects and know nothing for about 10 to 35 days, and then all of a sudden, do you get sick? You get muscle pain and high fevers. I've seen people seize from them. You again feel like dog poo with it, the sweating and chills. You know, it kind of sounds like a viral infection, but you have to put the bits and pieces together. If you went to Africa or South America, if you were in an area that had lots of mosquitoes, you know, you put together more than just the symptoms, and you end up becoming a detective and finding out the true reason for why they feel so bad. So antimalarials, let me tell you, easier to prevent than to treat. I've seen people who were affected with malaria from when they were in Vietnam, and it still causes them night sweats, and sometimes they even say nightmares. But now we're using combinations because they're finding drug-resistant malaria, if you can imagine. And then the medications we use, quinine, plaquenil, are the two that I've seen most, and what they do is they go in and wreak havoc on protein synthesis from the malarial protozoa. So nursing interventions, once you find out somebody has malaria and they're going to be starting on therapy, we want to know what their kidney and liver functions are. They should take the medication with meals to prevent GI distress, and report any vision changes. Avoid alcohol. Again, that's always a good idea, isn't it, with these medications? And make sure that if people are going to go to any of these countries with the nice red areas, that they take prevention with them, or they start prophylactic antimalarials before they leave. There are great travel clinics that help people decipher what they need to take, when they need to start it, and for how long. So I'm just going to quick touch on vaccines for you guys. I know that that wasn't exactly one of your assignments, but I have them here, so it's kind of fun. Immunity comes from different ways. We have natural immunity, which we just get related to our species, such as, let's see, there are certain diseases that wild animals get that we will not get as humans. There's passive immunity that somebody will get, like a mother will pass on to a child during childbirth. And then there's active immunity, which happens when we give somebody immunity from an injection, such as a vaccine. So there are purified vaccines, which have dead sort of viruses and bacteria in them, or there are live vaccines, and that's called attenuated. And this is what you see with the flu mist. You know, there's the option of the shot for the flu, or you can take a squirt up your nose. That's actually a live virus. It says page 503 lists of vaccines, but it's a different page for your book. These are just some of the vaccines that we can get to help prevent diseases. It's just amazing. And at what point do you stop? So flu vaccine, do you know why we have to get it every year? Because the flu virus changes every year. And there are so many different strains, and influenza just morphs itself. I don't think it has a brain, but it sure acts like it. So what they do is they look from the statistics from last year and what sort of influenza we had, and then they kind of decipher and try to figure out, okay. So in 2011, this is what happened. So I think that we should put this together, and that'll be our vaccine for 2012. And we hope it works, right? So that's why some people get the vaccine, but they still end up getting sick, because maybe it just didn't cover that one strain. So important to know that it's made out of eggs. So people who are allergic to eggs should not be getting these. And success rate is 65 to 90%, so that's pretty good. Most important thing is, especially for us healthcare workers, that we're not taking it and carrying it to our patients. And you know, how many people go to work or class sick? So varicella is a vaccine for chickenpox. And it's kind of very tricky as to who should get it. It should only be healthy people that get it. And they usually give children a dose when they're young and then repeat it kind of in their teen. So if you've had chickenpox, do you need the vaccine? Nope, because you've developed natural immunity to it. Your body has antibodies. So the next time varicella comes bebopping into town and tries to visit, your body says, no room at the inn. We are not having any of that. So this is, let's see, when we give it to kids, we repeat it when they're teens, and actually it's quite scary because I've seen adults get varicella and they get quite sick compared to a child. And there's nothing stronger than natural immunity. So I still, if I hear a rumor that somebody has chickenpox, I take my kids over there just in case. And it's usually, 2 doses. Okay, so the nurse knows that the following are true statements about flu mist, except: is it recommended for healthy individuals ages 5 to 49? Yeah, they can have it. Is it a live vaccine? Is it recommended for all healthcare workers? Not the live vaccine, because if you get the live vaccine and go back to work, you just need to go like this once and there's live vaccine all over the pens, the desk, and the patients, everything. So we usually encourage people to get the injection. And recipients can spread the disease? Yep. Okay, which is the most appropriate nursing intervention for a client who's taking antimalarials? So there's actually a couple answers here, I think. Nope, I lied to you. So B, because the antimalarial drugs can affect the 8th cranial nerve. In one book it says hearing, in another book it says vision. Hey, you can't go wrong if you get both of them checked, right? So you have a patient taking acyclovir. Vir means it's a virus. Which nursing intervention is appropriate for this client? We talked about it usually going in IV over an hour, so we're not going to push it. It can cause renal impairment, so we're not going to restrict their fluid. Drowsiness? Oh, but look at D. Encourage the client to perform oral hygiene several times a day. Haha. Frequent mouth care is a good thing because antivirals can cause the gingival hyperplasia. So D is the answer there. Okay, this is hard for me to talk about because I get a little bit grossed out, but I'm going to contain myself. And there are drugs called helminths, and what they do is they take care of single-celled membranes of the animal kingdom, which means tapeworms, roundworms, and flukes. Blah. Oh, true story. We had a boy that came to us from somewhere in Asia. It was a charity case, and he needed to have heart surgery. So they brought him flew him to the United States, fed him and kind of plumped him up a little bit, and made sure he was healthy. Brought him into the hospital a day or two before the surgery to just do some more working up. And he goes, "Wah!" and throws up. There's a big old worm in what he threw up. Well, now what do you do? Yeah, they took the worm and they sent it to the lab to have it sorted out to figure out, okay, what is that? Delayed his surgery, and he got some helminths, anti-helminths, medication to help get rid of that little worm that was inside of him. But you may see something about this. People are kind of talking about the fact that allergies are on a huge rise, allergies and asthma in the United States and other developed countries. And then they're kind of putting a comparison to, these are countries that do not believe in anything more than getting rid of every sort of parasite. So I've actually heard of people that have gone down to Mexico or Asia and purposely contracted or obtained these tapeworms. Was it a tapeworm or roundworm? I'm not sure which one it was. And he miraculously claimed that his allergies were gone. So I don't know. I'm not going to volunteer for my children to get tapeworm induction, but I don't know. Who knows where the future may lead, and we're hearing more about it. So meanwhile, I'm going to tell you about the medications to use to stop it. So when we're assessing for these sort of infections, we want to know what kind of foods have they eaten, how have they prepared them, where have they traveled, or where do they come from, and then is there anybody else in the family that might be infected? And it's important to get a stool specimen for a good proper analysis, because this is how it happens. People walking barefoot, and in countries that don't have good sanitation, there's excrement and it gets stepped in, and the worm goes from the body to the soil to the foot in a cut or sores of some sort, or it can be transmitted in the food that's being eaten. So the main thing with these medications is to watch for drug interactions with them, because they can affect Coumadin and how well you're clotting or not clotting, as well as other medications. Oh my gosh, I'm at the end and I realized I forgot to tell you my good story. So when we were talking about TB drugs and how they're not really well tolerated, well, true situation, I've worked at several different places, so you have no idea where this was and in what part of the country it was, because I like to travel a lot too. So worked with somebody, cough. Can you write me a prescription? So a coworker of mine writes a prescription for an antibiotic. Still has a cough a week later. So coworker writes for albuterol to help kind of break things up and a different antibiotic. A week later, still not feeling well. So he decides to go to the doctor. He has TB. So everybody who had worked with him in the prior 6 months had to be notified, which means patients too, and had to be tested again for TB, and then we had to be retested for TB 2 weeks later. He had to be pulled from his job, and then he went on all these medications. I think he was on quad therapy. And next thing I know, I think it was 2 weeks later, he happened to be in the hospital, and he's swinging at people and hitting people. And here he was having such kind of like psychotic sort of side effects from the medication, he ended up losing his job. So yeah, these medications are hard to tolerate, and I understand when people don't want to take them because I've seen it live, true, and in person. Hey, let's before we end, we flip your book to page 661 because there was a really good case study in there that I was looking at, and it was about amphotericin B. So here's a gentleman who drives truck, and he went in the hospital with pneumonia, and since then he's gotten quite ill. They sent some cultures of his sputum, and it grew out yeast. So before beginning his therapy, they look at the renal functions and the liver functions, his complete blood count, and they get a good IV in him. And I think this has to go through a central line because the pH of it is so potent, but don't quote me on that. So the nurse gives them Tylenol and an antihistamine such as Pepcid before starting the infusion. So you tell me, why did the nurse give them Tylenol and an antihistamine? Yeah, pre-med them before we give the medication to decrease our risk of reactions and interactions. The nurse is with the patient for the first 15 minutes of the infusion, monitors his blood signs. Cool. Why do we do that? Yep, watching for him to have some sort of reaction to the medication. And an hour after the infusion is complete, he calls the nurse and says that, he feels like he's going to vomit, he has the chills, he feels hot, and all at the same time. Oh my, what should the nurse do? Well, it says it's an hour after the infusion is complete. So first thing I do is check vital signs, right? And then I'd probably call the healthcare provider on. It's possible he just might need some more hydration, and that would feel better. They might redose him with the pre-meds such as Tylenol, maybe some steroids to help him feel better. He continues to feel terrible all night long, and so the next day they switch it to liposomal amphotericin. So he had been on amphotericin B, and now they're putting it on AmBisome. So the question is, why did the doctor continue the antifungal if he felt so bad with it in the first place? Because we're kind of limited with what we have to treat him with, so we have to continue it. If we don't continue it, that infection can overtake his body. So what's the rationale behind his order change? So amphotericin B is actually the cheaper of these antifungal medications. So we usually start out with that. Most people will tolerate it. But when they don't, then we can switch them over to, it's more of a lipid-based medication, but it's still an antifungal. So that's where AmBisome B, there's amphotericin B and there's AmBisome. AmBisome is the lipid antifungal, and people tend to tolerate that one a little bit better. So that's why they changed it. And I think that's it. You know what? Go ahead and send me any questions you have, and I will get them answered for you. My email is szeller@winona.edu, and I want you guys to have a great break, and we will talk to you later. Bye.